Welcome to your first mini lecture for intrapartum content. We are going to start with the stages and phases of labor and what those are, what those encompass, how those are influenced a little bit in the labor progression, and then vaginal examinations, dilation, effacement, and fetal station, and why that is such an important assessment finding for a laboring mom. So to start with, let's talk about the 4 stages of labor and delivery. The first stage is the contraction phase. So we start from regular contractions all the way to 10 centimeters. Now, we don't necessarily say we start at 0 centimeters or closed, because some moms will have dilation before active labor actually starts. So our first stage is from the start of regular contractions, regardless of how dilated mom is, to full dilation and effacement. So 10 centimeters and 100% effacement. That's our first stage. The second stage is from the time mom is fully dilated to the delivery of baby. So that's often referred to as our pushing stage. So the whole time mom is pushing to deliver baby. The length of the second stage is influenced by a couple of different factors. One of the most significant being if mom is a primip or a multip. So if this is her first delivery versus if this is her second, third, fourth delivery. Most often, not always, but most often, the first delivery takes the longest, and then subsequent vaginal deliveries are a lot faster. If a mom does not have an epidural, the second stage for the first time mom averages about an hour to an hour and a half. If that same mom was to have another vaginal delivery, her second delivery without an epidural, that time is cut down on average to 15 minutes. Those times are longer with an epidural because that does change the sensation mom feels and effective pushing. But regardless, usually multips deliver quicker as far as that second stage. The third stage is from the time we have delivery of baby to when we have delivery of the placenta. So we've kind of covered that normal time frame would be within 30 minutes of baby being delivered. We expect the placenta to be delivered. So if we're longer than 30 minutes, we consider that abnormal. But if it's longer than 60 minutes, a full hour, we do start to use the terminology of retained placenta and start looking into manual removal of the placenta, thinking that there's, for some reason, the placenta isn't detaching and delivering on its own. So we might need some further intervention. And then the fourth stage is from the time the placenta is delivered until about 1 to 4 hours after the total delivery. So this is recovery stage for mom. So once she is stabilized, her bleeding is controlled, and she is stable enough to be transferred into what we call the postpartum patient. We are done with the labor and delivery process. We have a range of 1 to 4 hours here because not all moms are exactly the same in this progression. I would say on average, this usually takes about 2 hours per agency protocol from when they start the recovery time until when mom is deemed stable enough to be transferred into a postpartum capacity. So where things get a little bit more confusing is we introduce some phases. So the only stage of labor, remember we have 4 stages, the only stage of labor that has phases is the first stage. So that time of which we have from the start of regular contractions until we're fully dilated. So the 3 phases are the early or latent phase, and you can use those terms interchangeably, the active phase, and then the transition phase. So these phases are all part of the first stage of labor, that regular contractions to full dilation. So the earlier latent phase typically has irregular, shorter, mild contractions that aren't always that frequent. So sometimes that might be every 5 minutes, every 7 minutes, as much as every 30 minutes. So mom is feeling contractions. She knows they're happening, but she's really comfortable during this phase, and they're not very strong rhythmic contractions. So we say this is roughly 1 to 3 centimeters, and I say ish because, excuse me, if a mom has had a baby before, especially, there is the probability that mom will be somewhat dilated, a centimeter, 2 centimeters, 3 centimeters dilated, before she actually starts actively contracting. And we'll talk about in class more of why that could be. So we say ish. So from the start of these contractions, we are in the earlier latent phase. Mom is usually very comfortable. She's able to breathe through contractions. She is still ambulatory. She can move around on her own. Her pain's pretty well controlled. The active phase is when the really stronger, regular, more painful contractions tend to begin. This is roughly from 4 to 7 centimeters in dilation. These are much closer together, usually every 3 to no more than 5 minutes. They're lasting longer, a minute, maybe more than a minute at a time. They are very strong, very palpable to the examiner through the abdomen. Mom might feel helpless, restless. These are really strong, painful contractions, and there's a lot of activity happening. So the active phase, mom is less able to ambulate freely or move around on her own freely. These start to be a lot more intense. The transition phase is the last phase of the first stage. So very strong, longer contractions, very close together, usually every 2, maybe 3 minutes. This is the 8 to 10 centimeters in dilation. Mom typically starts to feel very overwhelmed, especially if she doesn't have any pain medication or epidural anesthesia, anything like that on board. Very common phrase in the transition phase is, I can't do this. Mom becomes very overwhelmed. And usually the minute they say, I can't do this, you better have your gloves on because they probably are about to do this. So she may start beginning to feel the urge to push in this transition phase. We don't want mom pushing until she's fully dilated, however. So students tend to get a little confused when we talk about the different phases of the first stage. So just remembering that there's 4 stages. There's 3 phases of the first stage. And to keep these really simple and in order, we have 3 phases. The earlier latent phase, something is brewing, right? It's starting, but nothing's too strong and intense yet. The active phase, something is working. There's a lot of activity. We're really moving through. And then that transition phase, something's about to happen. We're at the end. We are about to deliver baby. Now we switch to dilation, effacement, and fetal station. So these refer to the 3 numbers you hear when we talk about vaginal exams in labor. And the numbers are always in this order: dilation first, then effacement, and then fetal station. So dilation is the measurement of the cervix opening. So we start at closed, right? The cervix is closed to begin with, and then we end at 10 centimeters, which is roughly the size of a large bagel for reference. So we go from very much closed, nothing can fit through, to 10 centimeters, and that's full dilation. Effacement is the measurement of that cervix thinning. So a cervix starts at thick. That's an actual term used. Thick refers to centimeters thickness. A typical cervical length when it is closed is upwards of more than 3 centimeters. And then we end at 100% effacement, meaning that the cervix has completely thinned out around the presenting part of baby, and there's no lip or no feeling left around the presenting part. So we go from thick to 100% effacement. Fetal station is the assessment of the fetal presenting part, which we hope to be the head, because vertex position is ideal for vaginal deliveries. So the presenting part in relation to the ischial spines of the pelvis. And if you look at a model of the pelvic structure, the ischial spines are right at the opening at the bottom of the pelvis. So when we do a vaginal exam, we are assessing the baby's head, hopefully, in relation to the pelvis opening. So negative numbers means the baby is higher into the abdomen, above the ischial spines. 0 means they are right even with the ischial spines, and then positive numbers mean down below, outside of the pelvis towards the exit. So positive, this is opposite of fundal assessments, right? We have positive and negative in the opposite way. So an easy way for you to remember this one is positive numbers means the baby's coming out. That's the goal of labor and delivery. If the baby's being delivered, positive numbers mean positive outcomes. So positive numbers means baby's on the way out past the pelvis. So when you hear or read in a question a vaginal exam, a cervical exam, the numbers are always in this order. So for example, if you hear or read, the cervical exam is 450 and -1. That would mean that mom's cervix is 4 centimeters dilated, 50% effaced, so halfway, and -1 fetal station, meaning 1 centimeter above the ischial spines is where the presenting part is. Another example would be if you see, so 8, 100, and +2. That would mean mom's cervix is 8 centimeters dilated, 100% effaced, so completely thinned out, and then the baby's presenting part is at +2 station, so past those ischial spines, that exit of the pelvic structure. So we are going to we're going to go over some models, and we're going to discuss the difference in these 3 pieces. But vaginal exam is a very strong assessment indicator of progression in the labor and delivery process. So that's going to be an important piece for you to know.